Yeah.
Okay,
Well,
yeah, read this sentence
detail.
before.
Read the.
Okay, are we ready? Call to order the Community Mental Health of Ottawa County Performance and Quality Improvement Committee meeting for Monday, November 10th. And as we normally do, let's review our CMHOC mission and vision statement. Take a few seconds to take a look at that. We do have a quorum today, so we can get right into the agenda. I'm looking for a motion to approve the agenda for November 10th, 2025.
So move.
All those in favor?
Aye.
Same sign. Okay, we'll move on to the consent items. Suggested motion is to approve the minutes for September 8th. The CMHOC, I'm sorry, Performance and Quality Improvement Committee minutes.
So moved. Support.
Moved and supported. All those in favor? Say aye. Same sign. Motion passes. First on the agenda here, appears we have a presentation by Dr. Brashears on outpatient therapy services rate setting.
Yeah, the next two presentations are meant for information for the committee and the public of kind of some initiatives we're starting to look at. So in your packet that's huge, you had the copy of the DBT stuff. It's past that. It's attachment A. I had to rip it out of because we have like the 100-page.
Yep.
Right. So this one says outpatient therapy, no-show rates, national and Michigan overview. It's on screen. And so we'll wait till everybody get there in your packet. You might have, you keep going.
I guess.
There it is. Now, why am I bringing this up? Why now is the question. Well, several of us are engaged in looking at many different types of service types we have and the rates associated with them, and then the kind of strategic plan in addressing the service by service type. And with this particular committee, anytime we're looking at, even if it's a rate, if it's connected to some type of philosophical change we may make in terms of how we deliver services or what it ends up with, I want to keep this committee in the know, even though when there's a rate increase or decrease, the finance committee and the full board will obviously take a look at that as well. So one of the biggest CMH distinctives that sets us apart from the private sector when we directly operate is the ability to cope with and deal with no-show rate. And so it's a huge factor in us looking at how much we're actually paying for non-CMH directly operated services contracts and setting the rate. And we're involved in a rate setting process, which I'll talk more about in a moment, that's looking at how much we're paying outpatient providers, because guess what? It's starting to crumble. The contracts that we have for folks to deliver outpatient therapy for the services we, like for the people that we serve, they're starting to fall off. And they're starting to say they can no longer do it for the rate that we pay, or some of them just getting out of the business altogether because of the requirements on the Medicaid side are so laborious, so like, forget it. So we're looking at directly operated models, contract models, and one of the biggest variables is outpatient no-show rates. So I thought I'd just briefly go over what the issue is, and then you'll understand in subsequent meetings one of the major variables is dealing with this no-show rate. Okay, they go to the next slide. It's thinking about it. So the national show, and I don't know if you can move that ribbon up a little bit, or if not, don't worry about it. The one where it's covering up the first.
I was hoping once I got rid of it or to the other screen, it would move. But
it's okay. I can just say what it is. The national no-show rate. This is when you look at outpatient therapy no-show rates across the board. For general outpatient, meaning folks that are getting moderate to mild level of care services once a week, maybe twice a week at a max, the actual no-show rate is 15 to 30%. So you book 10 appointments, you could have up to 3 of them not show up. Nationally, community no-show rate for CMHs is up to 35%, sometimes higher, but the floor is usually about 20%. Our folks that we contract the service for or directly operate usually have a little bit more of a severity of illness and need additional supports, right? And then I threw one in there because what's the effect of telehealth? A lot of this data was done during COVID and I had to kind of right size it. When you use AI, you have to verify and trust the data and go back and pull it in. So I ran kind of some studies, but really, so community mental health just nationally is up to 35%. We have a way of tracking that internally with the teams that we run, and I'll get the exact number for us. But for outpatient providers, one of the biggest things we're hearing, Jen and Katie on the kid side and Keith on the adult side can echo this, is the rate doesn't cover the amount of times people don't show up. In fact, the rate only covers fee for service when people show up. And so it's a gigantic variable that we've always dealt with. But private practices are able to turn people away when they have a no-show rate that like, you don't come the next 2 times, I'm dropping you. We don't have that ability. We have to accept people where they're at in the recovery and treatment process. And sometimes they're not in action phase all the way, but it poses an interesting financial dilemma and buying services for folks that could potentially not show up 4 times out of 10. So that's the national no-show rate. There's Michigan specific data I was able to get. It's the next slide. And you guys thought I was going to spend 30 minutes on each slide and be here till 7 o'clock at night. Okay. So Michigan CMH outpatient therapy, the average no-show rate's 18 to 30%. CMH Medicaid populations, we were able to get a Medicaid population data and it was up to 35%. And youth and families was 30 plus. So for youth and families, right? For youth and families, starting there. And most of our contract providers at the moment, we have some for adults, but we have some for kids. That's the rate. It's 30 to 30%. And if we don't build that in the actual rate, then our providers are like, we really can't, it doesn't make business sense for me to have somebody sitting in the office without getting paid 4 out of 8 times or 3 out of 8 times in a day. And so any questions on that data? 3 different sets, yeah.
If this were private counseling services, they would simply bill you a no-show.
They could.
They could.
Yeah.
Not Medicaid though.
Right, but Medicaid
Right.
can't.
Yeah, and you know, and like I missed my daughter Grace, and she missed somebody at Boston University. They sent her a bill. Like you didn't call within 24 hours. Of course, I had to pay it, right? But next time she will. But the point is, the private sector has ways of dealing with this. That if we replicate those same methods, it won't matter. We'll still lose providers, even if they do all of those things. Like, yeah, send reminders, and we have how to impact no-show rate later in the presentation.
Michael?
Yeah.
Yeah, just a question for maybe reframing this a little bit though too, is like, it's not about like how we can close them if they're no showing, but it's really looking into, is there any work that's being done as to why they're not showing up? Because that can also then become costly if they are not following up with services and then they require hospitalization.
That's right. And 2 slides from now, you'll see client level impact, system level impact, provider level impact that gets at the need for continuous evaluation, right?
Yep.
Currently, and I'll put Katie and Keith at the spot. We're not paying our outpatient contract providers the ability to do that type of follow-up. Like they're not getting paid indirect time to follow up with the client, go find them. Right, directly operated programs, we have more of ability to do that, and that's why we're more expensive. But if this doesn't get fixed, then they go to higher levels of care for sure.
Correct. Yeah.
But that's part of the problem. Our current rates for outpatient providers do not reflect any money for any of that work. In fact, we found out the private insurance companies are paying like 100, and I'm making up, I think it was like 167 per session, but it doesn't require anything outside the therapeutic hour.
Correct.
It's just what they're gonna get paid for that hour. You know, we're not there. So no-show is one of many variables that we'll be talking about in terms of the rate. So why, you can go to the next one. So why do clients miss appointments? Transportation and housing, scheduling conflicts, low engagement or stigma, lack of reminders of follow-up. There's a lot more I could have put here, like increase in acuity, like increase in their symptomology. Sometimes the last thing you want to do is go see your therapist even when you need to see them the most. Sometimes you're not motivated to do it, or the symptoms are too tough. But you know, transportation and housing instability, housing mean they're no longer in the area, right? Transportation issues, scheduling conflicts, we know. Low engagement or stigma, you know, that might be a contributing factor to no-show rate, but I don't tend to think, with our population, I think it's the level of acuity that someone has. It's not like, I don't want therapy. Most of the folks that we schedule there want to go, unless they're in our ACT team or some of the multidisciplinary teams where, you know, treatment compliance, or even some of the home-based treatment compliance is kind of more difficult. So this was just to get you say, all right, some of the things around no-show. If you flip to the next slide, we'll get to some of the impacts. So the impact of no-show on CMH service providers: interrupted care, you were referencing some of that, reduced engagement, worsening symptoms, equity concerns. So at the client level, it really is looking at the delay in treatment as being the reason why you want to solve this, and to assess if there are other needs. And one of the risk is increased risk of crisis or hospitalization, which, Paul, that was your exact link. And there's a disproportionate impact on Medicaid youth in underserved populations. So some of the outpatient therapy contracts we're looking at is on the youth and family services side of it. And there is, known in the literature, a disproportionate impact to that group when care is not available or they miss care. There's more of a systemic ripple effect with the family, with other systems they're involved in. So it's vitally important to ensure that that level of care is sustained enough to keep the providers delivering the care. I mean, you can look at the system level. If you have a whole bunch of no-shows, it's not like you can instantly fill them with other clients. So it actually reduces the availability for people to get slots in the continuum, because you can't fill them. You can't just, unless you had a policy like after the third no-show, you're gone. Well, for some of our folks, we just can't do that. We have to wait. And I will tell you, when you hear there's an access issue to care out there, you can't get in, some of it's because of this. It's because there are slots being taken up of no-show rates that are allowing providers to say they're going to reduce their capacity to deal with it. We had a provider tell us, like, hey, listen, I mean, I'd like to keep serving them, but I can't. It doesn't make sense to have 2 interns and a supervisor and all that stuff for half the people showing up, unless the rate would do it.
What kind of attrition are we getting, Michael, in general, in terms of providers? Just a thumbnail.
Attrition, you mean drop off?
People are dropping, saying, I'm not gonna.
We're at the beginning stages. We just had last month a couple of providers, like, we know that, I won't say their names because they may be listening.
Sure.
One just like totally dissolved. And we're actually, if you go to the finance committee and the board, we're actually getting contracts with individual clinicians that used to work there,
Okay,
so that we can keep the.
sure.
So at the agency level, this is definitely an impact, but we're not competitive at the individual level either.
Right.
We signed one new contract with me, Scouts Honor, saying I'll increase the rate in January, because they're like, I could sustain this for now, but I can't do it
Right.
for what you're offering, but I'm willing to let you go through your rate setting process
Okay.
and do that.
Good.
So go to the next slide, because we have so many presentations, I want to be mindful of that. All right, so, oh wait, is that the next one? The way my packet is, I don't know which one is the, hold on. Okay. So what are we doing right now? We're doing a rate initiative that has examination of current rates and the development of specific rate modifiers. And so we're gonna have a base rate, and I'm gonna show you an example rate calculator that's gonna give credit for things like no-show, things like we want the use of evidence-based practices, things like administrative burden. Those last three, no-show, use of EBPs, and administrative burden are not variables traditionally put into a rate when we're looking at this. But if you remember many, many months ago with strategic planning, it was keep the community and community mental health and become a center of excellence. If we want our providers to provide the level of care that we want, and we want them to use evidence-based practices, we have to assist them in having the infrastructure to actually deliver that evidence-based practice. Instead of saying the rate's $100, do good things. Right. And so we've had a couple of initial meetings, and we've had some changes even when I put this together, about what modifiers we would add besides what the base rate should be before you look at no-show, evidence-based practice, or administrative burden. So if you go to the next slide, you'll see like a structure of, and we've already met and kind of adjusted some of these things.
That's good, Michael.
Yeah.
Are these allowable Medicaid expenses?
They are.
If we build them in.
Correct. Mhm. And so knowing you, you're gonna say, so why haven't we done that before, right?
So why haven't we done that before?
Right? Because we haven't conceptualized it in the same way that we're about to. Like, we want to drive the type of care for our provider network, which includes evidence-based practices. We do it internally. You guys heard about DBT and all this other stuff that we're doing. We're building that in our cost of care. We haven't taken that step for outpatient providers because we may have assumed like, well, they're gonna do it, or they've been doing it for us without really acknowledging it. And one thing I want to make sure we don't have the collapse of the provider networks, residential, outpatient, and they're gonna appreciate this thinking. And even though this slide says 202, we're not gonna be at a rate, just so the world knows, at 202. It'll be less than that. But I had to come up with a base conceptualization to see how it would work.
Okay.
So we'd have a base rate of whatever, 110. What are we paying right now? I forget, like the base
139.
139. And then we're gonna build in a modifier of 10% of no-show. It's not gonna cover 35%, but we'll add a 10% of that. And then if they're using a very specific EBP that has a lot of oversight and fidelity, we'll go up to 30% or 20% or 10, just depending where we're at for it, to say, yes, use that, but prove it. We haven't made them prove it in the past, Tom, that they're using evidence-based practice. They may say it, but we're not looking at fidelity measures or scores. And then the administrative was just like 10%. You know, we've added so much administrative burden to our outpatient networks. 10% is laughable, but it's the only thing we could afford to do. There are new assessment tools that have to be put in place, new supervision requirements, new reports we ask people to do. And so I wanted to show this group that we're starting to look into this issue, but we'll look into it like, does it make sense to directly operate most things or to contract out? And when we contract out the service, are we clinically or from a center of excellence standpoint setting ourselves up for success? Or are we just kicking the can down the road for the provider every year to go, well, I can't do it unless I have another 10%. And we need to prove why it's needed from a clinical standpoint and a quality standpoint. And that's why I'm bringing it here first.
Mm-hmm.
So we have like next, just wanted to give you on this, like, so the next steps are meet with providers and review setting logic. We've already started that. Ensure the current consumers keep their provider of choice. We have a lot of clients that like our outpatient providers, and we don't want to see a retraction of that choice. Or we're gonna hear the only choice is CMH, right? And that would be a legitimate complaint about having an adequate network, provider network that allows for choice of provider. and determine the cost of doing it directly. So we're kind of looking at other models. What if we brought it all in-house? You might have a choice of clinician, but the agency, you wouldn't have a choice, right?
That broad range is going to be important because it works against the private insurance company's desire. One of their talking points of the LRE, the PIHP, is that they'll have more choice. We can mollify that by providing more choice within our system.
Yeah, but choice within the context of quality,
Exactly.
because there was a study, we had Dr. Louvers, if you're listening, he'll remember it. We did a study 12, 13 years ago, maybe 14 years ago, and it said, let's look at the cost of outpatient being provided only by contract providers and internally. He came back in, he said, good news, Dr. Bashirs, overwhelmingly, you'll save millions of dollars if outpatient providers do it versus you. Bad news, the outpatient providers are not seeing anybody.
Mhm.
They were seeing maybe 1 or 2 times before the client no-showed and lost contact with the provider. And so from a fiscal standpoint, oh my goodness, we would save millions of dollars by offering no service. We can't do that, but it's that delicate balance. Outpatient providers that we have are part of us. We should have the same quality and use of evidence-based practice expectations of us. I don't believe in outpatient alone. Do whatever you want and pray they don't get into a higher level of care. If it's for our folks, if it's for moderate folks or mild folks, it's a different idea here.
Mhm.
But this is for folks we would have to see, regardless if CCBHC was around or any other grant we have around. These are the people that meet severe and persistent mental illness, emotionally disturbed, family services issues, IDD adults that would
Mhm.
benefit from therapy.
Mhm.
Could I disagree
Please.
with you on?
Please
one
do.
point? I think it's just as important to the mild and moderate population that we provide effective and
You bet.
beneficial care. We can't afford to give them the short end of the stick. And I know you would agree with that.
I would totally agree with that.
What I'm wrestling with here is if we provided all these services with our own staff in-house, our customer would be the client who comes for counseling. By giving it to, outsourcing it to a private clinician, the clinician becomes our customer. We're negotiating with them. Here's what we're willing to
Sure.
pay. Are you
With
going?
monitoring, but yes,
But
I see your point.
so there's a change in dynamic
That's
when
right.
we do that.
Right, and we would say that we're still monitoring through supports coordination, case management, and other services, what's occurring in that outpatient environment. And some of that is administrative burden that we're putting on them to subject themselves to our questioning and those things that are not covered in the rate either. And so I would agree that the first point of contact, you're correct. But I have the same issue, like, do I really know what's going on in Keith's team with the therapy that's assigned there as an administrator? Well, I know more than I would if they were an outpatient provider alone, and we want to bridge that gap. And I'm not suggesting we should directly operate it all, because there are pros and cons to that, but I'm just letting this committee know we're looking into all those dynamics, because we're getting into a season where if we don't increase the rate for the outpatient provider network that we have and deal with these quality issues, they're coming to us anyway through access. We already have people that were seen by, I won't say the name of the health plan, one health plan or one organization that said we're no longer seeing moderate Medicaid folks, and they're showing up in our door and access now. And can you use CCBHC? Or we think they're severe enough whether you need to see them. And our network, the warning is we're at the beginning stages of the atrophy of it, and we want to head it out the pass. I don't want this to get to what happened to the residential system, where we have literally multiple providers saying we're putting in 30-day notices. And we're out of this business. We already had it with some of the outpatient providers, and we've been dealing with them. But we're trying to avoid that from happening.
Mm.
And I intend to bring this up regionally. We can't be the only people in this process. And of course, all this is happening now with all of the massive change dynamics. But we have to chew gum and walk at the same time. and deal with these things all at once. It's just adding complexity.
Mike?
Yep.
So with you're alluding to the increased expectations with the increased rates then too. So have those all been outlined as to what
Right,
those expect?
we're in the process of doing that.
And then does this require then a change in the contract because with each of them individually, because there's going to be increased
Yeah.
expectations about what's going to be coming?
This is sort of like the CCVHC program. You know, we're outsourcing services to
Yeah.
an independent contractor that we happen to operate.
Right, and so at CCBHC, we have to directly operate 51% of all of the 9 services together. Outpatient is one of those components that you might be able to have a subcontractor do with you, but you are correct, they're very similar in the dynamics of our ability to have oversight to the care. What I'm alerting this committee is that we're looking at different models. And we're gonna be bringing them back here for you to understand where we end up, directly operated or a hybrid of it, or here's what we ended up doing with the rate modifiers. The finance committee is gonna look at the dollars and cents aspects of it. You know, and then the full board gets to see the whole thing come together. But I wanted this to be upfront because we're having discussions about it right now internally. Because when you look, if you're on the finance committee, you'll see it, but on the full board, you'll see we have a couple of more individual outpatient contracts that we created because of this issue. They had left another organization, and hats off to the staff. They were able to say, well, will you stay on with us, providing clinician? They said yes, which keeps the client seeing the same person.
Will all those increased expectations, will those be outlined before the rates are
Yeah.
increased?
Mhm.
So they'll see what those are and,
And you will too.
Michael, have we looked at our own, people who we serve, what their reasons for the no-show are, or
Yeah, you know, that requires another look. But in the past, when we've examined it, it's really about, I'm gonna oversimplify, but it was really about increase in symptomology that led to less compliance. So the more treatment compliant they were based on the increase of symptomology, sometimes it's the lack of connection. And so I always look at how many of our clients are connected well with their teams. And are they, and the threshold is if you get somebody to see someone more than 3 consecutive times, the likelihood is that they'll go to 10 is much higher. If someone doesn't make it to the 3rd session, no matter where they're at, that's a danger. And you better go find them and figure out what's going on, because the likelihood of them to continue to no-show is much higher. And this is established in the research, the rule of 3 with this. And so we have some internal looking to do as part of this, especially if we go to a directly operated model. Are we just shifting the no-shows to us and the client's not really receiving any more or less care? So I know Keith's looking at stuff like, how often do we see people right now? Like how does that look?
do you have some idea, if you were to say, how many, what is our number of no-shows of people?
Don't know the number. The percentage is around 25% no-show rate,
Okay.
but I don't have the N yet. So like, I just know
What's the total?
historically. Do you know the total amount of people we have receiving individual therapy in the adults offhand? I don't know it.
Therapy only?
Therapy only or therapy in itself.
Patient.
Yeah.
Patient. Kids is about 130.
Okay. So realistically, if we were looking at 30% of that, it's not an overwhelming task to kind of
And
maybe reel them.
youth
in
are a
little
little bit more difficult because ours aren't kids that are driving themselves there. It's family issues which
Yeah.
are causing the breakdown barrier.
I understand what you're saying about dealing with the programmatic area here and the financial area in the finance committee, but they're intertwined.
Yeah,
For example, if we're doing the services in-house and we have a clinician sitting there and a client comes in, we have billable codes we can submit and be reimbursed from Medicare.
Mhm.
Medicaid rather. What happens if there's a no-show? Well, we still have to pay that employee. So we
That's
have a financial risk
Yeah,
of these
That's right.
things that cut down our billable hours.
that's right.
And if we go out and try to find them and track them down and give them a ride to come to therapy, is that a billable Medicaid expense?
Well, not necessarily. Some of our grants we have help.
Yeah.
But you may see the similar data than finance will. You may see the financial impact. I'm bringing it here to let this board, we're examining this issue from a way that not only says, what do we have to do, but will it cause a model change? Bringing more people in or keeping people out or all of those things. And I want this committee to be in practice of hearing model change, understanding we've had a philosophy change. I still may bring all of the financials to you as well, and then the finance committee looking at the impact of that. But you're in the front round, you're gonna get stuff way in advance of when we do that, so you understand we're looking at it.
So you're looking to bring this in January?
Yeah.
Good.
And just to beat the nail one more time with the hammer. If by using contract providers for clinical services, we're basically putting the financial risk in their lap by whatever rate we have negotiated, not having enough headroom in it to cover these discrepancies. So, there is a financial component of
Very
what
much
you
so.
just presented here.
Right, and so when you look at the finance committee stuff and you'll see it in the board, you'll say cost if we directly operate it. Because we're building in all of the stuff like no show and all that, because it's actually, the cost of care can look very much more if we do it than if an outpatient provider, because we're already building in those expenditures in there. We're not to our outpatient providers. So the heads up on this is we're looking at it. It
Right.
could lead to model changes that this committee will be aware of, this group will be aware of before implemented, along with fiscal impact, impact to consumer, impact to their families, impact to the community. All of these are the areas that we have to always look at. And so other CMHs just change the rate. They just go, yeah, we're gonna go 150 because we think it will help. I have to defend why we're doing it.
Right.
And what's the point of doing it? And so if they keep coming back to the wheel, at least we know what the measuring stick is. Oh, we underestimated this impact or that impact. So
It's an ongoing process.
And I compliment you on going down this road. I think that this is a great direction to go, but I still keep going back to the piece about like, if we're gonna increase those rates, it's real clear about what those expectations are.
yes,
And if a provider, are they given a choice? Because they may choose to say, it's
That's right.
not worth the extra burden. We don't have the resources
That's
to be
right.
able to do that. We'll just stick with the same rates.
that's right. And that's fine, but then we'll have diminished expectations, like not the use of EVPs. And then our referral
Yep.
patterns
Yep.
will dictate who really needs to be in that type of care. There's some people that are like, they're fine. Right, but it's the beginning stages of it not being fine in a very dramatic way.
I think there's a big difference too between, we have some contractual providers who really utilize a structure of interns. And then we have other ones who, specialize in, PMTO or parent training, very specific things. And so if the rate's the same, it's a little bit inequitable.
Yep.
And so that's part of what we're trying to get in here is that, and not all EVPs are considered the same, but there are some very specialized ones that are very different from like an intern-based model.
That's helpful.
Okay,
Okay, are we ready to move to the next?
yeah, the next one's gonna be very simple, right? It's not gonna go through each page of this.
Yeah.
I provided this to the group because I have asked the medical director and Keith, our director of adult mental health services, to look into the implementation, I should say the re-implementation, because we used to do it and do still do, of the evidence-based practice called illness management and recovery. And so what I put in your packet is a basic description of what that is. And I'll ask the board to go through it. And then at a subsequent time, I'll do a formal presentation once we figure out if and how we're going to implement it. But the reason why I put it in your packet is that, remember the whole part about CMH having distinctive programs. Why is CMH important versus any other provider? What if the state, no, excuse me, not the state, the Michigan Department of Health and Human Services, one person is correct that, gee, or we just need to have a choice of providers for folks that are much more in the CMH system. And I contend that our organization and most CMHers are actually implementing a form of this evidence-based practice as a philosophical underpinning of why we do what we do. It's the interface between what's called the psychosocial rehabilitation model and then dealing with people at different levels of compliance. So illness management recovery was something that was mandated for most CMHs to have a component of it 15 years ago. And then it fell off the radar. I think, Anna, you even used it in the Connection Center way back when. Okay.
We worked with Access.
We worked with Access to do it. And when you go through this, you'll see that there are certain components that says to the person, adult with mental illness or other folks, that A, you're just as responsible for your care as we are. And B, here are all the tools that we're going to help you to equip you with. Medication management tools that could be used for any population, right? It has stuff like understanding recovery as not being a cure, but part of a journey where your symptoms may go into remission. Viewing the types of conditions that we have of having personal, recovery goals and those things. And so I'm having it here for you to go ahead and read at your own leisure, but knowing I've asked the medical director and Keith to start meeting and with me and some group to say, if we were to implement this in a very formal way for our adult mental health system, how would we change it and what would be the impact? Because it's my belief we're already doing many functions of this, just the world doesn't know that we're actually doing illness management and recovery, which is an evidence-based practice. Because at CMHs, we are a center of excellence that use evidence-based practices. So I'm trying to codify all the ones we're using and then say, here's an overarching philosophy. And then Keith and I and the medical director had a meeting on Friday, and we decided that it merits looking and bringing to that system to say, here's what we're thinking. What aspects of this would we implement? Because it's very comprehensive when you go through it. And there's all kinds of fidelity measures and all kinds of things. But we actually had a working model of this many years ago, and certain components are still in place, but we haven't codified them again and really gone to fidelity with them. And it really will help shape how we interact, not necessarily the why we're interacting. It's the same reasons. So if you're thumbing through it and you say, how is developed, how is it delivered, individual groups, there's many different things that are part of this. When we get to the point where we've reviewed the evidence-based practice and we have an estimation of how we're thinking we would integrate it into our system of care, we will bring it back to this group to link the principles to what's actually going to happen. Because right now, if I go through each slide, you're going to say, well, how would this look? Or what would be the impact if we did it over here? Too early to tell, but my style is to give you a heads up months before we're bringing stuff back from you, just in case you hear through the grapevine. They're doing this IMR thing. What is it? Oh yeah, I have a handout on that. That's an evidence-based practice of looking at utilizing for our system with adults primarily. It has applications to the DD population as well and the substance abuse population. So we'll be looking at those aspects of it. But that's why I put it in your packet. Not intending to go through each one and explaining the evidence-based practice. You can go through it, and then periodically I'll give you updates. And when we have something like, here's what we're thinking, that's about an hour thing. Might be a work session for the who knows? That makes sense?
Yeah.
And I know you're familiar with this. Paul's definitely familiar with it. I had to implement this at CEI a long time ago. But that's in Lansing. So, when we're looking at next steps on this, we're considering it for outpatient teams, peer support integration, telehealth, all this stuff. It comes with a toolkit, all kinds of things. And attachment C is different if you're following through. But I'm keeping my promise that Center of Excellence Development is absolutely needs to be a continuous process here in CMH. It's what sets us apart. I mean, the Mayo Clinic may do it, but they got huge donors to fund like some of that stuff. We don't have any donors that are funding improving practices. The state used to. We used to get extra dollars to implement the EBPs, not anymore. It's all in the rate, like it's a spaghetti sauce. It's all in there. It's not in the rate that we get. But Paul, you can even remember when we had to have improving practice leadership teams at the CMH level, and we had to implement 5 evidence-based practices within 2 years back in the early 2000s. And that benefited us. We are a tradition of care that strives for excellence in the delivery of services, and this is one of the ways to do it. So that's why I put it in there. Not to say, hey, it's, but to have it. And if you're reading through it sometime and you want to send me a question, go ahead. We'll keep you up to date with the process of it. Any questions on that?
Ready to move on?
All right.
Okay, let's move on to old business. Keith, if you could present the MyFast scores and results and attachment C.
Do you remember we did the whole thing on DBT?
Yeah,
It was in your packet, right?
great presentation.
This was like, by the way, there was a fidelity review and Keith said he'd bring back the results. Here are the results.
So these are the results of the DBT MyFast review. The MyFast review was actually in July. And we got the report at the about midway through October. And so we've been looking over it. Overall, we got a score of 3.1.
Okay.
And honestly, we're pretty happy with that. We need to remember that, yeah, we were offering some DBT treatment, but it wasn't to fidelity. So now we're moving toward meeting fidelity and implementing it as an evidence-based practice, not just as another sort of treatment that we are offering. So with the score scale being 5 being the best, in 4 of 12 categories, we scored a 4 or 5. And those were in program philosophy, assessment, individualized treatment, training, and personal choice regarding service provision. What I'd like to highlight from that is that these are ideas and commitment to the program, which really cannot be trained. So these are the clinicians that are DBT trained, they have the right mindset for it. They're committed to the program. They're committed to learning how to offer those services and how to do them right. So like I said, those are things that cannot be trained, and we scored highly on those. So I'm very proud of that. Very happy to see that. We scored a 3 in individualized treatment planning, and that's a training issue. So we can certainly provide training for an improvement in writing those plans so that they're individualized to each client that is receiving DBT.
Can I have a question about that thing?
Sure.
Are you guys doing SMART goals then? Do you do the training for the SMART goals?
We do.
Okay.
Yep.
So I know that that's a challenging kind of thing to grasp a lot of times. I know that there's a lot of training modules out there. And I don't know if you guys are doing that at all. So
We are.
okay.
Agency-wide, we do that.
Okay. All right.
Were there ratings independently arrived at, or did they collaborate? Because it's remarkable that they're identical.
According to the folks that did the review, they independently did them, and then they came together and discussed them, and they came to a consensus. But as you said, it is remarkable that they were all the same.
Yeah.
Every one of them.
And I think that he's looking at that last summary page.
Yeah.
Mhm.
Well, might have you just put that up there, because I think it has all of them, right, from G1 to G12.
Mhm.
That way you're not going through each page going, what was it?
Yeah,
Yeah, and so the areas where there are 2s,
yes.
what do you think about that? And really, do you, I mean, it looks like we could move up considerably in those areas, like it.
Yeah, I identified those more as systems issues. So we scored 2 in eligibility or consumer identification. supervision, process monitoring, outcome monitoring, and quality assurance. So for the monitoring, we don't have anything in place right now that is using either our system auto or our quality committees to monitor any of the outcomes for DBT. With auto being new to us, I think that the capability is there. And from what I've been told from other CMHs, it is there. And then for like a quality committee, that would just be, we have to start getting that going. And because we are moving toward fidelity, that is something that will have to be started. Eligibility or consumer identification, there really was no process for that in place. So there will be a process put in place very soon. I've already started working on that as a way to work all the way from when they come into access to start the identification process.
Is that G3 you were talking about? I got distracted.
Yes.
Yeah. Yeah, so it's utilization, right? The penetration.
Two.
Oh, two, okay, yeah,
Yeah, we'll
because
talk
they're
about
related, right?
G3 in a little bit.
Okay, I'm sorry.
And then with supervision, again, because we're moving toward fidelity, we're trying to make sure that our DBT lead is being given the time and availability to provide that supervision. I know that there's a weekly review that she is providing, and we're working towards some more individual supervision, which is one of the recommendations that came out of this fidelity review. And then we did score one in penetration, that is G3, and that is defined as the percentage of people who have access to DBT as measured against the total number of people who could benefit from DBT. I have already have a rough draft of the process for making sure that we have better penetration for this, for making sure that people have access to DBT. And I will be going over that with the lead. And also then I will bring it to whatever committee I need to bring it
That's right. You
to.
have plenty of them.
To make sure that we are doing a lot better at identifying and making sure that those folks are in the program.
But your capacity isn't real, I mean, your ability to have many more clients isn't that great from the
Right.
presentation, right? I mean,
Yeah.
so it may impact your need for additional. staff.
Correct.
Yeah,
Yep.
we want to get to 5, we gotta add all kinds of stuff, for sure.
Mhm.
What I like about this approach is think about any service we have, that we're evaluating them across a wide range of stuff, supervision, access to care,
Right.
penetration, individual. And so that's why the use of these fidelity measures, some of these things are good, so we can expand them out to a lot of the things we do to say, do we know what we're doing actually works and people actually feel like they have choice in it. So I like the structure of it, even though we have room to improvement, it's a good overlay. I'm glad we have the fidelity review, but you are right, without additional resources, penetration is not gonna get past a 3. You know, I don't care what kind of flow chart you got, it's gonna be hard to do it if you don't have the people to do it.
Right.
Mhm.
But expanding that outpatient network to doing DBT, that we just talked about, with the fidelity measure and paying them a little bit more increases our capacity. And so that was some of the thinking when we met about the other issue that you were bringing up with EBPs.
Is this an annual review?
It is not, it is every 3 years.
Every 3 years, okay.
We can always contact the state and ask for guidance, or if we're really struggling with something, we could ask for an earlier review,
Sure.
but it is every 3 years.
Okay.
So you were reviewed 3 years ago?
No,
Okay.
So
this
is
was
your
the first review, I think, since 20. So it's like starting.
Yep.
So this is our baseline.
Absolutely.
Okay, all right. Yeah, I was gonna say, how did we compare with previous scores, but it's probably all different.
Whole
then.
different world
Yeah,
back
okay,
then.
yeah.
Yeah.
And does this require a corrective action plan then too, or?
It does not, because they fashion it more as, we're trying to help you.
Alright.
Versus this is what you need to do. So no cap, but kind of it's
I'm sure if they were all like twos and ones, they'd be saying, you're not actually doing the thing. Stop saying you're doing it. You know, but
And it's useful information that you heard, or that you, the feedback that you got back from them, that you can implement some changes.
Yes.
Which is good.
Mhm.
Any other questions?
Yeah.
Thank you very much, Steve. We'll now move on to old business. I'm sorry, we're in old business. We'll now move on to the LRE residential services rate setting.
yeah, just, you know, as you know, we had developed a process in our own rate calculator. I'm happy to announce that the region has done their own analysis and used our rate calculator as the model for them to look at implementing region-wide with some modifications to it. They plan to orient the CEOs of the region this Wednesday of their work, but Leah and I got a chance to look at how their rate calculator and assumptions related to ours, and they're almost identical. They actually added some things we didn't think of.
Hmm.
And I think the result will be a validation that our approach is actually covering the true cost of care for residential providers and the drive towards quality we want, accepted at the regional level. This is helpful to us because it's both a validated tool that we'll be working with that isn't too much different than ours, but it will say, the region will have to then say, how does this impact all residential services in the region? What type of rate differences would they be if we applied the calculator? And if regardless of our partners, if our partners don't agree with this in the region and refuse to do it for whatever reason, which I don't know why, but they could, we will still do that in Ottawa. We'll take their regional calculator, compare it to our results, which we just went through, do a crosswalk, see what the difference is, and then work with the region and come back to our CMH to say, hey, here's the difference, and we're gonna go with the regional method or keep our own or whatever. But it was a very validating experience, especially for our residential services folks that have been working diligently for the last year to put this together in partnership with every residential provider, not just the big ones. And once we have all those results, we'll bring them all back. But I just thought I'd give you an update, like, hey, this is good news.
Good. Excellent. We ready to move on? New business, access and crisis utilization report.
Yeah, if you could put it on the screen. I try to bring this every month, every 2 months, actually. Thanks, Keith.
Thank you. Thank you.
So. And I probably should have had to go first, but this is fascinating to you, still. Okay, I'm like, oh yeah, she's last. So we look at this every 2 months, right? And so we look at crisis contacts coming in, inpatient, result in inpatient stay. If you looked at the report in the packet, if you go to, if you can just go to one of the last slides with the line charts, it's easy for me to, right there. So when you look at the trending for both crisis and then below the bar graphs for access, the crisis and the things associated with them, crisis residential, step down into crisis residential, partial hospitalization, all those things. We did still see the trend go up with inpatient admissions versus crisis utilization. You see the, what was that, burnt or salmon?
Mhm.
And the blue, right? And they happen to be statistically, when they're in line like that, it means there's more of a correlational relationship than I would want. I've been double checking with the team if any of the folks that were admitted to the inpatient program, would they go into Robert Brown? Remember, that was a crisis unit we shut down.
Right.
And I am monitoring it and meeting with staff today, we're going through it again. But I am alerting the board that we are still seeing an increase in inpatient hospitalization. We're not sure that has anything to do, as much as it may appear, with crisis residential utilization. We're double checking every admission because it's above that 25% threshold we've been looking at in terms of hospital admissions. And we peaked in August. Well, in May we had the biggest peak, but it's September to October we saw an increase in that. And it's really looking at who's going into the hospital. I initiated this today, an ask where how many of the folks that are going in the hospital are being seen by us currently in one of our teams or an open client versus who is brand new to us, we
Right.
never knew. And what percentage of which is do we see a dramatic increase in the ones we're currently serving, which can lead to no-show rate and other things, right? Or we just didn't know them and we're stabilizing them. And so I'm adding that layer of evaluation to this to help explain the increase. It can't just be, boy, something's in the air. The seasonal trends we can look at. I've been collecting data like this only since certain dates. I can't go back too long. The other thing in our assessment and eligibility, we're still seeing that once somebody gets past our screening, that 91% of the time through assessment, they're being open for services. And we're looking at our screening tools, like I told you last couple of months, to say, well, how is that? Like, is the screening tool, it's either so general that everybody gets to assessment or it's screening out a lot of people before we even get to assessment. And so we're looking at the relationship between the screening tool and who's assessed, because when you look at eligibility, if you go back a couple of slides, sorry. Next one. What's the next one? Is that the Brian? Yeah, right there. So you look at it, 127 people in that period got to assessment. Only 9%, 11 people were said you're not eligible. So is that good or bad? It does highlight the doors open for certain groups. But, you know, if we're at 91% of people getting past the screening tool to assessment tools, do I need the assessment tool at all? Right, I have to do it by law. But because everybody that's getting to assessment primarily is getting in. So why put the burden on that person for a full assessment? I mean, you need it for other things, level of care and stuff. But when you're looking at it from a pure tool standpoint, it's like, well, I guess you get past the screening tool, you're in. You guys are seeing that, right? And then we have it broken up by division. So like autism, only one person was ruled out in that period, according to the way that we gather this information. Okay, well now we know why we have a continuous increase in autism expenditures, right? These are real new people coming in. Our system is not allowed to keep growing at the same rate as people coming in. You look at IDD adult for that time period, only one person was referred out, 17 people were accepted into services. You look at MI adult, 44 people were found eligible, only 4 ruled out. And I go on and on and on. In this period, no one can say that CMH turns away people after assessment, that no one can get in. Now, I'm looking at the screening tools to say how many people didn't make it to the assessment piece. And that's where there's some nuance in looking that I got to rule out, but I will bring that the next time. Does that make sense? I mean, you look at the numbers, you're like, no wonder why we keep our Medicaid expenditures keep going up. The front door is wide open.
But is it fair to say that those people are entitled to services?
They're absolutely entitled to services, and we shall provide.
So we're doing a good job of
We are.
identifying them. We're not just.
We are not utilization managing out folks due to the budget. We are saying you meet eligibility, you're entitled for the service. Let's get going. And that's important for people to understand. We can't do what other businesses do. Sorry, we have a deficit. We can't see you. And I spike the football every other month on this, but it's really a distinctive of our system. Tom, just wait if they change the system, and we're not doing the front door at all. I worry what will happen to people's entitlements. Call the mega center down in wherever with 33 other CMHs. Good luck. They're not doing that. Tell you that right now. And if they're listening, I apologize. Maybe you'll have a better plan. Because people listen to our meetings. Well, that's that report. And every 2 months I do it with you.
Michael, I'd
There
at
you
some
go.
point like to see the, out of the 116, how many of them actually did show up, you're saying, but
Oh, yeah, yeah.
if they were no shows from the assessment to
Okay.
start treatment.
Yeah, so start a treatment, like from determining eligibility.
Or to
start-
assessment, I mean, to assessment.
Yeah, to assessment, but like,
Yeah.
from that, right, start a treatment.
Yep.
And then maintaining treatment.
Yep.
Okay. All right, that's good.
Other questions? Thoughts? We good? Okay, Anna, you're up. Dashboard.
So this is our utilization management committee dashboard. So we have a utilization management committee here that meets monthly. It consists of leadership team, so the clinical directors, myself, Dr. Brashears, and also our IT team. And we are going through a matrix of reports that we have probably 25 different reports that we're looking at throughout the year. Not every meeting, because that would be, I think, information overload for everybody. But we do look at a variety of different things to make sure that we are monitoring services, how we're providing services, the efficacy of our services, looking at spend downs, people on Medicaid, all these different factors to make sure that we're utilizing our resources as best we can. So this report is put together to share with the board twice a year, typically. So we're bringing this to you. It has a snapshot of what we're looking at. This is not a comprehensive report from that committee. That committee does create a utilization management plan annually that is reviewed. At that time, we do review all the reports that we are looking at and determine, are those the correct reports that we should be looking at? What are mandated reports from our funders and DHHS? So Michigan Department of Health and Human Services, CARF, which is our accrediting body, the HSA group, which I can't remember what that stands for off the top of my head, but that's one of our auditing groups that looks at what we're doing. So again, this is just a snapshot of that. And the first two are what Dr. Brashears just covered. So I won't go into great
Right.
detail. And Dr. B, if you have anything to add with these.
No, just the graph to the right is numbers, not percentages, and
Yes.
okay, just, it's not
Yep.
10%. If Katie was looking at that, she'd be like, what? So it's the number of people, and it's from a different time period.
Mhm.
And I actually think my other access report's a little bit more accurate, that this is close to the same area code of what we were just talking about.
So the time period is a little different. This is looking at from the implementation of our new electronic medical
Right.
records. So you'll hear us talk about Otto here pretty regularly. That was June 1st that launched. And that's looking at new eligibility screens that were done after that point in time. So when you're looking at that, what you'll see is that the largest group of people requesting services are adults with mental illness. And as noted in the description below, that does track with previous reports that we have put out. Amanda, if you can scroll down to the middle figure. So this is talking about our hospital readmission rate.
Yes.
The Michigan Department of Health and Human Services requires through our Michigan Mission-Based Performance Indicator System, MIPIS is what we fondly call it, that we remain below 15% on hospital readmissions within 90 days. But what we're showing here is that within 30 days, we have 6% of people being readmitted to the hospital. 60 days, 7%, which includes the previous 6%, and 90 days, can't see that far, 8%, which includes the previous 7%. We are well below the state standard, which for me as a leader here, that shows that our clinical teams are really doing the hard work. They're meeting with people when people are discharged. We're meeting with them right away. We have contacts that are being done through our navigators. I believe Carrie spoke about that at the board meeting last month. We're really doing the work to make sure that people are, if they're in the hospital, when they get out, they're getting the treatment they need to stay out of the hospital.
And it's my understanding the MEMBIS indicators are going away. Is Ottawa going to continue to monitor these indicators then?
At this time, we have planned on monitoring most likely this one This data is easy for us to access in our medical records. Some of those Nimbus indicators, you're well aware, are
Yep.
very complicated to access and to analyze. So we have one indicator for Nimbus that we will continue. It's indicator 2, which is length of time to start up service. That you will probably see on further reports. But I would anticipate we'll continue this. We have not changed our year-end plan to update for Nimbus.
The national standard's 30 days. So nationally, people, they collect the other ones, but it's universally accepted that recidivism happens within 30 days. Once you get to the 60, 90 day, it's still, you want to look at it. But if you Google it, 30 days comes up as the, because that's most associated with the last episode of someone being in. But it's still, it's low.
Really good numbers.
And is the national uses that all cause readmission, like for physical health or behavioral?
Well, I was only talking about psychiatric.
Yeah.
And then in our bottom 2 charts, the one on the left is looking at the number of Medicaid covered lives in Ottawa County. So this is how many individuals in Ottawa County have Medicaid. As you're looking at that, you're going to see there was a steady incline until 2023. So this is accounting for the pandemic when people were getting on Medicaid and they were not being disenrolled from Medicaid. So we did see a steady increase in enrollments. And now with the public health emergency unwind, we're starting to see a decrease back. I'm hopeful that if it levels off at where we were in 2019, that would be good.
Right.
As you are aware, that our funding is based on the per member per month with Medicaid. So it's really important for us to monitor where we are at with the number of people covered with Medicaid in Ottawa County. Not that we're responsible for making sure everybody applies for Medicaid, but it's very important for us to monitor.
You see the utilization rate goes up.
It's ticking up.
That's Dr. Bashir's famous quote that the system only assumes that 94% of the people on Medicaid won't show up.
Right.
We're only funded to really serve between 6, maybe 8. Imagine if 11% showed up. Imagine if 15% showed up. Imagine if they matched it with prevalence rates of mental illness of 20% showed up.
Right.
We'd be bankrupt unless they funded us based on that versus that.
Interestingly, if you look at comparing the 2 graphs, with the increase in Medicaid eligibles, we did not have an increase in consumers seeking services.
We continue to serve the people that we already serve.
Right.
Yeah.
The same
Which is
group.
what makes it challenging with our funding being tied to that, is that we continue to serve the same amount of people, whether there's more Medicaid covered lives or less, but our funding is tied to the number of people, which is a challenge.
Yeah, and it's a level of care issue. If we're still prioritizing the most severe, you might not see a correlation between the increase in Medicaid lives, because it's the same 6% that we're serving, or 7%, which was my point. Like, they really want to do it right, tie it to mental health, IDD, substance use prevalence rates. In terms of the number of Medicaid people expected to be served would be closer to 15%. Imagine if we got funding based on that way, we would be in a far different spot.
Without getting too much in the weeds, are there any initiatives trying to get the formula changed?
Yeah, the current one is to restructure the PHP
No,
system.
never mind.
To
Okay,
start over in a
Okay.
sense, but yeah,
okay.
there are a couple of initiatives,
Gotcha.
yes.
Good.
Some more robust than others.
Yeah. Thank you. Thank you. And then we'll move on to the performance improvement plan for this year.
So another lengthy document.
Looks like a lot of
very
fun.
Large
Yeah.
packet. So this is our annual performance improvement plan. It really is a living document.
It
We're
is.
looking at this all the time. But we are required to bring this to the board of directors for review and approval annually. So we are bringing it to you to review. I was not going to go through this in extreme detail. So if you want more detail, feel free to set up time to meet with me.
Right.
I'm happy to talk through it. So this performance improvement plan is required by the Michigan Department Department of Health and Human Services. I'm trying not to talk in acronyms for you,
I
so
got you.
if you catch me hesitating, it takes my brain a minute to remember what they are. So this plan is required by that group along with CARF, the Lakeshore Regional Entity, and our other federal funding partners that we work with. It's really looking at ways that we can continually improve the performance of the organization. So using continuous quality improvement activities. This document then lays out the goals of our performance improvement plan. We want to make sure we're efficient with the resources we have, that we're continuing to look for areas that we can improve on. It also discusses what the plan requirements are, what our responsibilities are, how this performance improvement plan fits within our structure. And then it goes into detail on all of the different committees
These are
that we
the list.
have. As standing committees, so these are not board committees. These are committees that our staff are participating on that are addressing different performance improvement initiatives. So we have our behavior treatment review committee, our clinical case review committee that's really looking at when people may need higher levels of care. Our pharmacology, I can't read it sideways, and therapeutic medication committee. This committee is really working on our prescribing practices here. This is with our medical director and prescribers coming together to review policy, ensuring that we're doing quality work. Utilization management committee, which we discussed. We have a compliance committee, which also creates its own compliance plan that walks alongside of this. That committee's looking at all of the fund compliance requirements that we have here. We have many regulations that we need to follow, so that's really the group that's looking to ensure that we're following our regulations. We have a consumer advisory panel that meets, I believe it's quarterly. So that group is led by our community programs director and then reports directly to Dr. Brashears, or if he's able to attend. That's a way that the people we serve can give direct feedback to Dr. Brashears. We have a health and safety committee, information technology committee, health information management committee. That's really the land for our clinical records. Our medical record lives there. If we want to make a change to that medical record, that committee is looking at it to make sure it's not just impacting one department. If it's impacting every department, and you might not be able to, it impacts everybody. So it's an organized way for us to review those changes. We have our personnel and training committee, recipient rights, provider network, fiscal services team, who is always here to support us. And then our access center team, which Dr. Brashears just went over all of the really great work that they are doing out of that. As you go further into the plan, you'll see I highlighted all of the organizations that provide monitoring.
I would
So it's
imagine,
on page
yeah.
11.
I would imagine with all of those monitoring devices that you guys are in compliance. There has to be one that's continuously happening all the time.
Always is one happening. Yeah, if there's not one happening, we're preparing for one. So yeah, we're currently being audited by the state for waiver programs right now. Then we're gearing up in the winter to have the Lakeshore Regional Entity come, and then CARF is going to happen, I think, in the fall. They have extended our accreditation. It was expiring June 30th. We're extended through December 31st. I believe that's because they don't have folks to come out and do our accrediting visit prior to June. So we have regular visits from a variety of auditors. And when we have areas we need to improve on, we develop CAPs or action plans that we can improve on those services. We report back to those auditors. There's a highlight of some of the reviews that we do have. And then at the very end, you can see our structure for our performance improvement plan. So it starts with our board of directors and then works down through the chief executive officer. So Dr. Brashears, then the performance improvement plan, and all of the plans that support this plan. There's a lot of plans. I don't include those plans here. If you want more detail on those, I'm more than happy to share that or talk with you about them. This is really the overview, holding everything together for us and driving the work that we we do. out of
And
our-
from the plan, do you develop like new goals for the upcoming year? I don't see that in here. I don't.
Yeah, so the goals, the way we're doing it is through departments. So our departments go through semi-annually a review of performance improvement activities they're currently working on, and then ones that they want to add. And then I review those to stay on top of what we're doing. Then our quality improvement committee looks at those.
Okay. So based on this report, I mean, it's like, how does this then become actionable? So you take this information and what do you do with it then?
So the action piece is that piece that's the directors that are working through which areas they want to improve on, what they're working on, along with our various committees that are doing different performance improvement
Plans
projects.
that are sitting there, right?
Mhm.
You
Yeah.
know,
Yeah, the plans move into action with this. The committees are also doing that work. We have a quality improvement committee that really focuses on the performance improvement activities of the organization.
yeah, and you know, the trick is now that we have other resources. I mean, if the community reads this plan, you read this plan, you go, oh my goodness, A, I didn't know it was, and B, where are the results? How do I see the results ever
Mhm.
of the plans? This is great. You're all working your butt off, which we are. So we're gonna have to create some dashboards associated with some of these plans
So that's,
that are publishable. A lot of times it does include healthcare protected information, but we can kind of change that.
Right.
But eventually, there should be connection with the performance improvement plans and a couple of dashboards, maybe not for every area, that anybody can see all the time, where it becomes, trust us, we're doing all this work.
Mhm.
The work is extensive. Like, I'm still blown away with how many times, like, I didn't check my email all day because I was literally in a committee meeting all day, one after the other. But it'd be hard for us to put in a manageable way at the moment. Here are the top 5 results for each one, and here's what we're doing. That's where we need to get to. So that the plan is something you're approving annually, but you're aware of stuff throughout the year. And that's why this committee started off as every other month, but you can
Right.
see
Yeah.
we could make the case every month and just, but that's what my goal is, because there's so much here. I mean, just staying on top of it is really, you've been doing a great job. Like, every single one of these areas is quite laborious. And we have them a lot of them reported to the leadership group, and then it's disseminated out. But what to give the board and then what to let the general public see, we got to get to that next level. So that you can take this plan and go, oh yeah, that's related to this dashboard they have over there. And some things wouldn't be appropriate for public dissemination.
Right.
Some things would.
So I will, if there are no other questions, I'll entertain a motion to approve the PI plan as presented and forwarded to the full board with a recommendation for approval.
So moved. Or
All those in favor, say aye.
I,
Aye. Opposed, same sign.
I do have one question.
Okay.
Do you have time for anything other than meetings?
I do joke that
Thanks,
that's what I do, is go to meetings. And I
There you
squeeze
go.
things in where we can.
It's the coordination of it all, too, right? Not just the attendance, just like that. But that's a good question.
Thank you for your efforts too. Appreciate it. Finally. System of Care Grant Overview with Katie and Jennifer.
I think I'll kind of just provide a little bit of commentary at the beginning, and then I really want to turn it over to Jen. If you look back at the access utilization data that was up there, it's a little goofy looking because autism is pulled out of family services. Those are both children's programs that, that we manage. And so our numbers are the highest. It hasn't always been that way. We were typically lower than adults with mental illness. We are the fastest growing and highest number of kids that are coming in. If you compared that with kind of agency budgets, department budgets, you would see that family services is not the largest budget by any means. It's actually probably one of the smallest. People like Jen have done an amazing job to see what else is out there besides Medicaid dollars for us to be able to strengthen really the service array that we have for kids. And through her work, we've been able to kind of maintain our budget where it's at while really providing some enhanced services. And so I think it's really important that you guys get to meet Jen, hear from Jen. She has done an amazing job with this. And yeah, but I think that really fills the gaps of a lot of the stuff that prevent kind of me from coming back and seeking additional dollars and stuff. That this, especially the System of Care grant has really
That's right.
funded that. So go ahead, Jen.
Well, thank
Let me
you.
just say one thing. So it's back because remember, we talked about this at the full board when we were in finance approved, like we got the grant. I'm like, we'll come back and tell you more about it at the next PQI meeting. It's just the sequencing was off. So this is closing a loop of those discussions in the different committees when the System of Care was brought up. We announced we got the money and all that stuff, and people were like, so what is it again? So that's why we're here.
Well, thank you for having me. The presentation's about 10 minutes, but I'm definitely open for questions, and I could talk all day, but I'm trying to keep it to 10 minutes. So thank you for the introduction, Katie. So we're the Ottawa County Collaborative to Strengthen Youth and Families. That's a mouthful, right? But we exist to identify and bridge gaps in services, equip service providers, create community dialogue, and ensure children in Ottawa County have access to the
I don't think
supports
we
they
have this in
need.
the packet.
Oh,
This
Yeah,
is,
you do that.
Okay.
oh, I'm so sorry.
It's not
I
you,
will
it's
make
not
sure we
Yeah,
get
I'm
it.
sorry, I was gonna walk to.
Okay.
About that,
So
everybody.
Paul's looking for it. I'm like, no, it's not
So
there.
sorry.
We will get you copies, yes. So I'll kind of refer to like what we actually do to address that mission and purpose. If you want to go to the next one, that's some of the team there. We did a little retreat lately, so
Who's
there
that
they
in the
are.
back? He's hidden.
Khaled, you can't quite see his head. Yeah, the tallest. A lot of people refer to us as SOC, System of Care, because those are the funding dollars that we get. You can move it. SAMHSA, right, federal funding organization, they have the System of Care dollars that are all over the country. I think people in Guam have System of Care dollars. And so it is, the purpose of these dollars is to provide resources to improve the mental health outcomes for children and youth, birth through age 20 with serious emotional disturbances, and to support their families. So the SED that we see coming in through our doors every day. When I started, there was already a System of Care grant in place. They had gotten an approval in 2020. So I came in 2022. That first grant brought up to $1.8 million into our system. How they work it is the first 3 years, it's a 3-to-1 match. So for every 3 federal dollars, we match with $1, and we use millage dollars to offset those costs. And then we've learned a lot in these 4 years, and we've made really good programs. We've provided some great services. Let's continue these efforts. So we applied again, we're approved. And then now that could bring an additional 2.8 million in funding. So I'll go over a little
Total.
for the 4 years total. Yep. And I'll go over a little bit about what we did in the first grant and then what we're looking at doing right now. So just some highlights from the first grant. Created and administered a children's mobile crisis program. Probably heard about that in the past. So that's offering in-home mental health crisis diversion to families, whether they're in the CMH system or not. And really the goal is to divert them from inpatient care or the juvenile justice system or whatnot. Because once they go into those systems, it's much more expensive, right, to treat. So we're trying to triage them into addressing the situation at home and keeping family at home, and then getting them access to resources in the community, whether that they come through our doors or they go to other resources they're eligible for. Just overall, we assisted about 575 individuals, not just with mobile crisis, but community health worker services. That's a program with the health department. It's really case management, right? Walking alongside the family, helping them get connected to resources to address physical and mental health related issues. We got some staff through the organization and in the community trained in this trauma-focused cognitive behavior therapy, which is an evidence-based practice. And then they were able to utilize this with consumers out in the community.
What timeframe was this again? Because
2020 to 2024.
Okay,
This is
so
our first-
This was our first
year.
grant.
the first thing we had 575. Okay, gotcha.
Yep. And then we provided mental health services outside of the CMH doors as well. We know that not everybody can or maybe needs the level of care that we have. So those other entities we partner with, sometimes they would come through their doors and get assisted with these funds. So the next slide. We did a lot of training, not only for our staff, but just local professionals around the community, training parents, training youth, and other community members on mental health related topics. So that could be QPR, which is question, persuade, respond, or it could be like mental health 101 for YMCA camp counselors, right, that are going to be working with kids and going to see some mental health challenges and barriers. We offered our trainings free to the public. And then for social workers like myself, we have continuing education requirements. So we were able to partner with the LRE to get some of our training approved and then provide that free to the community. So it gets more people coming to our trainings, and then it's a service to them because they don't have to pay for some of those trainings. So our grant dollars supported those efforts. And then we completed an anti-stigma campaign, which included the creation of a website, which I have these to pass along. The idea is that we wanted something to be maintained. So we are continuing to maintain that, providing resources, whether it's community resources or even state and national resources for people that maybe aren't calling us, but maybe want to go and look on this website as a place to start. So what we learned in those 4 years was that we needed to enhance our collaborative partnerships, which I think is always a goal of this community. This community does a great job of partnering. So when you have that goal, it is much easier to accomplish than in some other communities I've found. We needed to increase direct services for youth and families, particularly those case management services, and then mental health services. So whether that be therapy or therapy related services. We wanted to continue our existing programs and the free training services. And then we wanted to provide more consistent hours for mobile crisis. So what we're doing right now, you saw that there was an increase of potential funding that we can access. So things that we are, that included in our new grant was one, a collaboration with West Ottawa Public Schools. We hired a mental health clinician who is a CMH staff member, but they're working with that school, particularly their middle schools, to identify kiddos that maybe are having some behavior issues in the classroom, and then linking them to, okay, are they having things going on at home, right? Are there resources? Are there direct services we can provide those kiddos, or do we need to get them connected to resources? So instead of expecting them to come into our doors, we're kind of going to them and hopefully helping get them connected to resources. And we're trying to look at those kiddos that don't maybe necessarily qualify for Medicaid or CMH services, because they're the ones that can't come through our doors, but maybe are getting, dropped in those gaps in service. So the nice thing about the system of care dollars is that it can look at not just people in CMH, but our larger community system of care for mental health.
Just to say something about that quick, Jen, we're doing it with West Ottawa. We're in a pilot model. And so they were really willing to kind of work with us to say, hey, we have a general idea of what we want to do here and what we think can be useful. Can you help us kind of shape that? And I think we've already learned some lessons there, but they've been a great partner for us it'd be, in a perfect world, we'd have somebody we could embed in every school. That's not going to be the case. So how can we kind of develop a model, and then either through school funding or something else, we can, try to sustain that. But the goal really is, you have somebody who can provide, say, short-term wraparound services to a kid and a family, and then hopefully prevent them from accessing our services. And we are seeing a lot of, instead of really true like mental health needs, we're seeing a lot of food insecurity, housing issues, that type of stuff that the schools really don't even know how to manage. So good lessons learned so far, but really that's in a pilot.
Yeah.
I appreciate that, because one of my things is to advocate for more programming in the east part of the county. And so I'm glad to hear that this is you're getting data, and hopefully you can present that to some of the other school systems.
Yeah. And there are other, like here, Katie said, there could be other players involved, and maybe local dollars, right, to help recreate these efforts at other schools or other districts. No, at the moment, we're kind of creating it on our own based on our own needs, but I absolutely, as we learn, I think we want to best practice model with what's out there.
And if, those of you who are familiar with the school system, Bonnie, I know, you've been in, and they're really looking at things from an educational lens. And so when you're evaluating something like a need for social work and that type of stuff, it really needs to be impacting specifically in that classroom. And so if we can come in with a different set of eyes and say, what are those things that are happening outside? That is typically better for the kids. So I don't know, maybe we'll create something fun here.
But is it more on the West Ottawa side, identifying and navigating and assisting versus providing direct therapy?
Well, there are some direct service provisions, and we're trying to figure out what ones make most sense for CMH, and then what makes most sense for families needing services, right? So, our collaboration with the health department, right? We needed more case management services. We're finding that initially the school said, oh, our kids need mental health services. But as we break it down, it's like, I don't think they need mental health services as much as their family needs like access to resources. So that's what we're trying to still figure out. How does it end up
I can give you kind
working?
of an example of kind of our first case that we had. We had a 18-year-old boy, and so our grant goes up to the age of 20, but an 18-year-old boy who was going to be a senior at West Ottawa, who had been asked to leave his adoptive parent home, and so was kind of sleeping on different couches, and but was really at risk for not graduating from high school. And so our clinician was able to step in and really do some individualized work, secured housing at an agency that's able to make sure that he finishes high school, do some of those steps, apply for Medicaid. You're 18 now. How can we do that? And those were all pieces that the school's not going to do. It's not really CMH's in traditional senses lane, but now we have a kid who, is going to hopefully has some successful outcomes. And so those are the type of kind of situations in which we're working in.
Yeah. So yeah, he might fall through the cracks, right? Otherwise, so trying to hit those kiddos with, maybe non-traditional needs, and then figuring out, okay, how do we systematize this, right? So we're gathering a lot of data right now, and we're already looking at it going, okay, we have additional things we can discuss with the school. I think our collaboration with that community health worker partnership with the public health department will be great, because we have some of those families who don't quite qualify for that program, but could utilize that resource. So our system of care dollars can help that family. We are working on a parent cafe. I'm not sure if you're familiar with that, but that's really an evidence-based model that looks at working with parents and just providing a space for them to address their parenting challenges with other parents, and looking at protective factors such as resilience and communication. And so it was really just bringing families together monthly. We provide a meal, we provide childcare, and just bring them together. How are you handling some of your your challenges with being a parent. And that was really something we had seen as a huge gap in services. So we we were getting really good traction, and then of course we had turnover. So now I'm trying to partner with some other organizations. They're trained, we have the dollars, and we have some of the staffing and the resources, and we have the year of doing it. So how can we combine efforts and make it more affordable and get
Directly
more people?
operated, now we're looking at contract.
Exactly. Yeah. So contract some of those.
Is it open for all families of all disability groups?
Yes, technically it's open to anybody. We wanted to target parents with children who have either mental health or physical health needs, just because we're partnering with the health department's special children's needs program. So we just thought if there was some commonality that might get parents to go, just like there's a parent cafe for men, and like it's all dads, it's a dad's cafe. So we were just trying to find something that connected our families. Yes.
How many encounters typically do you have in a year with children?
Oh, with this, so that's a great question, because we're typically, we might have encounters with the kiddos, but then they're also having encounters with other parts of our program, right? So that's a hard one to answer. I am working on that. SAMHSA has changed how they want us to track our service provision. So we're figuring that out right now, because they want us to track how we're following kiddo in system of care from like assessment to like exit, but they don't necessarily want us to duplicate services. And it's like, well, a kid could be in 5 different services at one, in one quarter, but they want an unduplicated count. So we're still kind of figuring that encounter data out. So I guess stay tuned for that. When I said 575 people serviced, they could have been serviced in a multitude of ways.
Could be times whatever.
Yeah. So still working on that, but it's I'm all about data, outputs, and outcomes, right? Like who we serve, but how are we serving them and what difference are we making, I think is really important. So we do have those strategies.
Does that have, do they do youth mental health first aid at all?
Yes.
And is it tied, do you coordinate with them at all to provide?
We do, absolutely. Yeah. In fact, Arbor Circle did a training for a lot of our staff who do mobile crisis, particularly the ones that aren't the clinical staff, but the support staff. So that would be an organization we partner with and maybe provide some SAMHSA system of care dollars so that they can go out and train the community on youth mental health. So we don't have to get trained and spend the money on it. That's where we can partner with our
Yeah, and they're great at
collaborators.
working with school personnel to identify
Yes.
symptoms of stress related to trauma or something like that. And
Absolutely.
working with them to initiate services right away, so it doesn't
Yep.
exacerbate into something much bigger, so.
Yeah.
Yeah, that's great.
Absolutely. That's I'll mention, actually, this is the perfect slide. So we're engaged with a lot of community collaborations that address youth and mental health, family needs, right? So the Ottawa County Suicide Prevention Coalition, Building Resilient Youth, the SCAN Council, these are all county initiatives and community initiatives that are addressing these things in the community and how do we best serve and not duplicate resources? How do we, best support each other, refer our consumers, and then collaborate to share dollars? Yeah.
And these are all non-Medicaid services.
Yeah. We're not billing Medicaid for any of these services.
This is the community,
Yep.
part
Yeah.
of community mental health. It's
Right.
not the Medicaid health plan.
Right.
And if system of care grant went away,
A lot of people, yeah. A
We
lot
live
of
in
services.
silos.
Right.
DHS lives in a silo, CMH lives in a silo, the education system lives in a silo. And so this is really trying to say, how can we,
right,
and you can have conversations until you're blue in the face, but they always end with, well, how are we going to afford this?
yeah, who pays
So
for it?
this is an avenue for us to be able to jump into that territory and say, how can we get those agencies to fund?
It stops It's not our problem, it's their problem.
Right,
Right.
Another
right, yeah.
bucket.
Mhm.
Yeah, we have a governance board, DHHS is on it, juvenile court is on it, Arbor
Okay.
Circle, a lot of the partners that are providing similar services. And so we're coming together and saying, what are the needs of the community, right? What are we hearing? A great example, social media, right? Parents are like, how do I address social media with my kids, right? And even professionals, how do I talk to kids in therapy about this, right? And so able to collaborate and bringing, experts on this topic, not just to talk to the professionals, but then also to parents and youth. So on that website, we have a bunch of links to some of the data, and people are finding that really helpful because they're like, I didn't grow up with this. I don't know how to teach my kids about it. So that came from multiple agencies saying we need some training on it. So that was a great way to use the system of care dollars. Again, we're going to continue to educate those service providers. Like I said, 2,200 service trainings. That's where that would be an output, right? Some of those folks might have gotten trained on more than one, but 2,200 training provisions for local staff and community members. Yep, you can go. And then I just kind of wanted to show you the positions. One thing that I think is really important, and I have a lot of experience. I worked at a nonprofit for a long time. And so it's always like, how can we do things? How can we more strategically do them? How can we do them cheaper? How can we collaborate, right? And so if you see, a lot of our positions are similar, but I've added to them. So some of that is just needs and better triaging of the work that we're doing. We're not necessarily doing a one size fits all. We're having people come to us saying, I need help from here to here, and then service providing for them depending on their need and not just a one size fits all program. So we've provided additional direct service provision and updated a few of our positions. The transition coordinator, I really want to highlight. That one is specifically for, Katie mentioned our autism services. That is a very large population of people we service. Most of those kiddos aren't going to, once they turn 18, they're not going to go over to like our adult IDD or DD services. These are services they're eligible for now, but probably will lose in a traditional sense. And then, families are like, wait a minute, I had all the support through either school or mental health or whatnot, and now I've lost it all. So we do have somebody that is helping those families transition, right? What do you have to think about when your kid turns 18? If they're looking to graduate, are there other like employment or education programs that might fit the needs of those individuals, right? And so just having somebody to walk alongside them, we found would be really helpful. So a great, I guess, story from that is we had somebody who was just transitioning from this our CMH to another CMH on the other side of the state, and they actually will maintain services, but they wanted to go to college over on that side of the state. So our transition coordinator got the process set up to get this person in services, but then also what do you need to think about as a new student, right? Like living on campus. So like got them a bike and like helped them register for classes and things like that, because they just didn't have anybody else to help them. So kind of helping them transition into the next stage of their life.
Is it on call 24/7?
It is not on call 24/7. I will say that the mobile crisis, so children's mobile crisis program, they are working on getting that to a 24/7 model, and not to just include children, but adults as well. So I had been overseeing mobile crisis until October, and then it went under an umbrella of all crisis services. So there's an internal restructuring, and now Tim Pierce will take that on. So we can still continue to fund some of those positions and use system of care dollars, but I won't do the day-to-day oversight.
I'm so sad about that.
Yeah, I know.
Scheduling and
Part of the CCBHC.
We do have 24/7 mobile response capabilities. So
Yes.
Tim, the director of crisis, has set that up. It's, so the children specific is the hours that they were. We have people trained in children's mobile crisis, which is a slightly different model than mobile crisis.
Sure.
Mhm.
Yeah.
So the mobile crisis for adults, they're able to respond 24/7.
So with the model, they probably require certain positions you have to have, like in the, I don't know if the 0.75 is, that's like a requirement for the. You could hear,
That's actually just separate. Right now, the on-call, so we changed to an on-call staffing model just because it's, it's a chicken and an egg thing. It's like, okay, we're not getting a lot of calls, so then people aren't busy, but then you're not staffed and then they're not going to call. And so it's like, so doing an on-call allows for a cheaper way to make sure that we're covered for services. So a lot of staff here will sign up for on-call shifts.
Okay.
So there's a clinician, which it needs to have at least a bachelor's of social work or related. And then there's a support staff, which could be like a youth peer or somebody else. So that's how, versus somebody, on call every shift, right, for those positions.
And just to clarify on the transition coordinator, this is not the general fund requirement for adult to use transition. We have other processes for that, people that would be eligible for our services. This is in addition to. So we have a mental health code requirement to assess youth to adult transition in the big systems of care. That's where it's a lot of improvement still, but it's part of what we're supposed to. This isn't that.
Thank you. Great.
This is outside of that. So just want clarity.
This is at 300 and some kids that at some point are going to kind of just fall out of the system but still have need, right? But there are some, resources in the community we could connect them to. It's just parents may not know them. So it's kind of a warm handoff process.
And so right now, those kids are all in West Ottawa, that those 300 and some. And they might receive the support of the mental health clinician or the transition coordinator.
No.
No, actually so yeah, I know it gets a little, so like the mental health clinician position at West Ottawa, that's specifically for students. The transition coordinator and some of the other positions, those are internal positions. So like, that person would work with somebody already in the CMH system. However,
It may not always be West Ottawa.
Exactly. Yes. Great point. And some of those West Ottawa might already be CMH, and then we just get them connected
So
to
the
other
majority of
CMH.
services on the list are not West Ottawa specific.
Right. That's
They're
just a
countywide.
special program that we decided to do with them. Most are, as Michael said, community-wide. Yeah. But thank you for clarifying. When it's me and I'm talking about it, I've talked about it for so long. It's good to, have other people ask those questions so I can clarify it.
Good.
So do you have any other questions?
Questions?
So.
Great.
Out of my seats. I love this info. Because, I used to work with families and help them with special ed.
Right.
Yes,
Yeah.
I know so many families. that,
Right.
Yeah.
this would be
And,
so
and
helpful.
we're,
Yes. And that's our, that's kind of the step too, is not just those families. Okay, so we have families within CMH, but how else can we hit those other families, right? And it could be going to schools and, at a school family night and saying, hey, is your kiddo in services and, not going to transition on? Here's some information you should know.
Sure.
So ideally, we're creating it internally, but then to expand it out into the larger community and do some larger education and information. Because sometimes parents just need a little bit of guidance to get there. And then sometimes people need more, direct assistance.
And how many times I heard parents say, I didn't know that existed.
Yes.
So that's the.
I didn't know
Yeah.
some of these.
So that is the goal. Some of these are new, so we're still kind of, we're smaller, but the idea is to expand.
Great stuff.
Thank
Really
you.
good stuff.
Thank you.
Okay, got any other questions? We'll go to public comments. Anybody want to give public comment? Anybody online?
People online, but I don't think they have their hand raised. Nobody with their hand raised.
This meeting is adjourned.
Thank you.
Thank you for everything.
Yeah, a lot of information.